All right, so we're going to do physics talk here, sort of half physics, half actual PET pathology stuff. And so the title of the talk is going to be emission tomography. So that sounds fancy. Basically, it's SPECT and PET. So just to rehash a few things here, separate a few things here. So gamma photons versus X-rays. So just sort of a big ballpark, big picture difference is the gamma energy is going to be energy that is emitted from the nucleus. So you have some kind of you're having a decay event, and in that situation, electron being captured. You're having a conversion within the nucleus, and then energy is being emitted. Versus X-rays, which you're losing an electron, and then one's dropping down, and then the energy difference is resulting in a characteristic photon emission. So that process is taking place within the electron orbits, whereas gamma process is taking place within the nucleus itself. So three basic imaging types, all of which generally work by detecting gamma photons. Now, differences here, whereas planar and SPECT, you're looking at isometric transitions, which generate detectable photons. PET is, a beta positive decay with a positron. So just quick refresher here and rehashing a little vocabulary. Remember, everyone wants to be happy, and there's this band of stability, and depends on the excess neutrons, excess protons, that kind of stuff. There's decay that occurs towards that band of stability. So that decay, that ratio changing between neutrons and protons, that is an isobaric transition. Well, what the hell does that mean? It means the mass doesn't change. You didn't gain or lose any mass. So remember, neutrons and protons weigh about the same, or have the same mass equivalent, pretty damn close. So converting from one to the other doesn't really change the mass. Neither of them are actually getting ejected or anything. There's just a transition between the ratio there. The atomic number can change, because remember, that's dictated by the number of protons you have, but the actual mass is not. All right, and then after that, you have this thing called an isometric transition, which typically occurs after an isobaric transition, where the nucleus has all this extra energy, and then it emits a gamma photon on its way to a ground state. So you have something sort of like this, electron capture kind of thing, and then you have this part here would be your isobaric transition, and then this part here would be your isometric transition, and this is the part that's actually generating the photon. Alright, so planar and SPECT are your single photon emissions, right? And PET is that dual photon stuff, where you have the positron that's emitted, travels a small distance, collides with an electron, they annihilate, you have an annihilation event, and then 180-degree photon emission, 511, right, in each direction. So it's two, as opposed to planar and SPECT, which is just a single photon coming out. So just a rapid review of what a gamma camera does or is. So a bunch of different components. The first part here is the collimator. The purpose of that is to block unwanted photons, off-axis radiation, complement scatter, etc. Allows you to correctly localize an event, discriminates based on the way that stuff comes in. If it's coming in off angle, it's assumed to be scattered and gets blocked. If it's coming straight in, then it's assumed to be originating from something you want to look at. It can't tell the difference between photon energy. That's done by the photon height analyzer. So next is your scintillation crystal. And basically, what does scintillation mean? It just means something that is going to release light when it's like impacted on by a photon. So you have the photon lands on the scintillation crystal. The crystals are made of sodium iodine doped with thallium, and it's a magical property where it will release a pulse of light in response to getting hit. And then that light is detected by your PMT, your photomultiplier tube, which detects light and converts it into electrical signal, which is measurable. And the more of these you have, the more light you can pick up, and the greater your resolution. And they don't just record the signal intensity; they also record the location. So you're getting a location on an XY axis, and then a signal intensity. And then so your coordinates go into one computer, and your signal intensity goes into a gadget called a pulse height analyzer. This thing. And the function of that is to sort of discard background crap. It only looks at photons from the tracer you're looking at. So remember, you can get background crap from a whole bunch of different sources. Compton, iodine escape from the crystal itself, it's a backscatter. So it's analyzing that. And then lastly, you have a computer, and that actually makes the picture. So, hey, wasn't this a lecture supposed to be on emission tomography? What is emission tomography anyway? So it's a mechanism for displaying and computing 3D distribution of activity as opposed to 2D like flat planar. Emission tomography is basically a fancy word for PET or SPECT. So the best way to think about SPECT is like this. So plain film X-ray is to planar as CT is to SPECT. So it's like the CT version of planar. All right, so here's your patient. So he's laying down. So SPECT is old, it's like 40 years old, and it's a really, really basic way to understand the gamma camera. Is basically you take one or usually two cameras, and so just to orient you, this is the top of his head, there's his feet, so he's laying down. And you rotate these cameras. So yeah, the photon energies are coming out of the patient, and then you're rotating the cameras around, and they're picking it up as they go around, picking it up. You get the idea, and then that is creating like a 3D thing. Once there's some math. So piece of trivia that's worth knowing is that SPECT is depth dependent with regard to like sensitivity. So sensitivity is getting attenuated at different degrees by different tissues. SPECT is more susceptible to that than PET is. So where SPECT is a single or a couple of cameras sort of being rotated around the patient, PET uses multiple rings of detectors, so there's no rotating. It's fast dynamic acquisition, way faster. SPECT takes forever, but the PET portion is faster. And there's a whole bunch of different internal checks that allow for accurate localization. So 180 degrees coming out there at once. So let's talk about the crystal differences, and that's kind of the reason I reviewed that camera to start with. SPECT is basically a gamma camera. It uses a sodium iodine, just like a regular gamma camera, but that's a scintillation crystal. And the purpose of that is it gets struck by a photon and emits light, and then the light gets turned into an electrical signal and that kind of stuff. PET has to use a thicker crystal. Why? Because you're dealing with 511 keV photons, because it's PET, and those are like super duper, like iodine 131 is like in the 300s, right? So this is like 500, so super duper high energy. So you have to have thicker crystals. So, and there's a couple different ones that are used there. So there's this concept of a line of response, and basically what that means is it allows so you have two detectors all the way around, so it allows identification of the origin of the annihilation event. So you have things come out like this, and then it does some math and says that's where it came from. As a result, PET is way more sensitive than SPECT, like 100 times more. Resolution is better again, because it has the full ring, and the SPECT camera doesn't have that. It's the depth issue isn't a problem. All right, so there's this idea of a coincidence detection, which is basically, we'll go back and we'll look at that. So these things come out around the same time and they land about the same time. So within a very short, and we're talking very short time interval here, that is considered to be like, ding, that was a real event. That's how it decides it's real. They land at the same time, so then it knows. One on each side means that because they're always coming apart at 180 degrees at a time. As opposed to something like this where, one lands and then the other one lands and there's like a time difference, so that would get rejected, so that doesn't count. So it's, systemic check. It's checking for these pairs to occur in a short-term time window. So you'll hear 2D PET versus 3D PET. So the difference basically is that with 3D PET, it's not just one row of detectors, it's multiple rows of detectors. And, in 2D, each row, acts like its own unit. And, it's got like lead septa employed to prevent like oblique photons from registering. And then you have, algorithms like CT, filter back, iterative data reconstruction in the axial plane, and you end up with a stack of transaxial images to complete the data set. So to increase the sensitivity, each transaxial slice includes some coincidences between the adjacent detector rings. So that's 2D. Now, 3D, the septa are removed. That's the testable point. So what's the difference between 2D and 3D? No septa for 3D. Okay, and because of that, you get way better sensitivity because you're acquiring coincidental events from any pair of detectors, and you have a scatter algorithm that's used to compensate and improve the geometry. So that kind of stuff. So 2D has septa, each ring does its own thing, sensitivity suffers as a result. 3D, you lose the septa, and sensitivity is better. Now, what are the septa made out of? They're made out of lead, because it has to be thick enough to block these high energy photons. Alright, so let's talk about some ways that this thing can screw up. So different kinds of coincidences. So the idea, a true coincidence is, two 511 photons result from a single annihilation event. They go out at the same time and they're detected in that same 180 degree plane. A scatter coincidence would be something like this. So one comes out this way and the other one comes out 180 degrees, but on its way out, it bangs into something and ends up over on the side there. So then the detector thinks that it actually originated like that, because that would be 180 degrees. So it's it's falsely identifying the location of somewhere else. Now, another kind of situation is the random coincidence, where you have one event here and one event here, but the computer thinks that it actually sort of came like that because those would be like 180 degrees apart. Alright, so there's another vocabulary word you need to know, which is like this idea of time of flight. It's basically the same concept where the time between when these two things land on each other, you can do some fancy math and say that I know it came from here because of that, the subtle time differences there. So time of flight basically is a thing that enhances spatial resolution and image contrast by taking into account how long the subtle differences it takes for these things to land as a coincidence on each side. Alright, so let's talk about something else PET does. So PET, when you think PET, you usually think PET CT. And the CT part of PET is done for two reasons. It's done, one, so you can get some good anatomy and tell what the hell's going on. And two, it's done for this reason, this idea of attenuation correction. So we've got red and we've got orange. So this top one is the uncorrected. Look how hot the lungs are, look how hot the skin is. And then the bottom one is the corrected. So it's basically, this is performed, it's a correction that's done for different levels of attenuation the photon might go through on its way to reaching the detector. You know, think about it traveling through bone versus traveling through lung, and, you know, use the data from the CT to tell, oh, it went through bone, or oh, it went through lung, and then there's math that's done and it does a correction. So why does that come into play clinically? So this is the classic trick right here. History of melanoma, deliberately trying to trap you. All right, and then we look at the uncorrected versus the corrected. So this may not be projecting well, but just take the lungs are hot. Lungs are hot, and the skin is hot here. And yet we're not seeing anything up here. There's actually a cold spot here. It's like photopenic. And then we look down here, and we got a hot thing. Okay, so that's why you look at the source imaging, because now we can say that that's some kind of a correction error. So on the uncorrected data, there's nothing. And on the corrected, suddenly it's super hot. Well, why is that? It's because it overcorrected for attenuation because of a metal thing. In this case, a pacemaker. That's the most classic example. So don't call a pacemaker a melanoma met. That's the trick. Barium can do the same thing. That's why usually barium's not given, because the bowel could look super hot and you think everybody's got colon cancer because they've got barium in there. It would overcorrect for the attenuation. So what is the mechanism of FTG? So it's, I'll have a whole talk on mechanisms, but FTG is a facilitated diffusion, basically carrier-mediated transport across membrane, like think about it like a revolving door, where it's a type of diffusion which requires a concentration gradient. It's not active transport, but you do have a like a door, like a revolving door that's open, and this door is sort of selective, so only certain molecules can fit through, and you can have competition. That's an important thing. Like if you have a really high blood sugar, it can affect how much sugar actually gets into the cell. Because there's a limited number of doors. Think about it like that. So you can saturate the doors. Alright, so something like this. So there's this GLUT transporter, and glucose enters cells through this transmembrane protein transporter, something like that. And they're labeled with F18, which is a fluorinated deoxyglucose. Similar, it will come right through the GLUT channel, just the same as regular glucose. And then so they're both in there, the regular glucose and the FDG that's labeled. And so then you have like this phosphorylating thing, and they'll both get tagged. And that's what traps it in the cell. And then your regular glucose is going to end up in the glycolytic pathway, but your FDG is not. Now, basically, important thing to remember is that the phosphorylation traps it in. It comes in through a no active transport, doesn't require ATP, but does require like a channel that's specific for glucose, and it can be saturated. This like revolving door can be saturated, so that's why elevated glucose levels matter, and they can decrease cellular uptake of FTG. So let's just rehash that. So if your blood glucose is too high, let's say more than 200, what will that do to your SUV? So if you're comparing them to the prior exam, they may appear artificially low, right? Because they got outcompeted by that glucose. What if the patient is overweight? So in that situation, they may actually be falsely elevated because fat takes up less glucose. All right, so, and then you've got, more of it floating around. So, all right, so what is this SUV? What is this thing? It's basically, well, it's not a Hounsfield unit. Hounsfield units are calibrated to water. Basically, there's multiple factors that go into the SUV thing, and that because of that, it's super variable from institution to institution, and even from patient to patient as well. But basically, it's concentration at a certain time interval times a patient's weight. The weight changes, that's why it's different from patient to patient, divided by the injected dose activity. So, fat versus skinny people matters. Lean body mass, you'll see some of these tumor staging things that want it things equalized to lean body mass. That again, you'll see that be different. Basically, it's just remember it's variable. It's not the same. Like a Hounsfield unit in me is the same as a Hounsfield unit in you is the same as a Hounsfield unit in a kid. It's all zeroed to water, and SUVs are not like that. They're variable depending on how much dose they got and what their fat muscle distribution is and breakdown weight and stuff. So we said that SUVs in fat people are often high, but is it possible that they could be low? And the answer is yes. There's this thing called a truncation artifact, and it has to do with the field of view from PET and CT. Basically, you got a big fat person that have several, layers of blubber outside of the field of view, and therefore not providing data for attenuation correction on a CT part. Imagine, like the big pannus that sticks out. You don't even see it because the bowel's in the pannus, and you don't even see the bowel because it's outside of the field of view. And because of that, it makes the attenuation correction stuff not accurate. So maybe because fat elevates SUVs, and then you could have a truncation artifact, maybe they would equal out and it would be normal. But just know, if there's a question specifically mentioning truncation artifact, it can falsely lower your SUV because their fat hangs out of the scanner. So let me just clarify a point about this truncation artifact also, because just saying it's high or saying it's low is probably a little bit about half the story. So basically the difference is the field of view for CT tends to be smaller than the field of view for PET. So if you have a fat person who has part of their body hanging out, you probably have noticed that like that rim right as their blubber is hanging out tends to look like hyperattenuating, like it's denser. And then let's say that this is the cancer and it's like half hanging out and half hanging in. Well, the part that looks like it's hyper attenuating here is going to get like, you're going to have attenuation correction errors that occur here and occur here. And what can end up happening is that the stuff that's sort of at that rim, or even a little bit like more inside of that rim, like let's say there was a tumor here, it would look falsely elevated. And then stuff that's outside of that rim, it receives no attenuation or CT data at all will look falsely low. So it depends on where it's at. So stuff that's, there's overestimation of activity corresponding to the image rim, and then underestimation in a region without correction factors. That would be like outside. So it's variable. The difference occurs because of the field of view differences. But yeah, it can mess up, can make stuff look low on a fat person, is my point. Alright, so what about this guy? What happened there? A lot of muscle uptake. Alright, so typically this is, when you see it diffuse like that, that's insulin. And the insulin is, if you remember how insulin works, it puts glucose into cells. And specifically muscle can do that too. So all the glucose got shifted into his muscle because he just took his insulin. Now you can see it more localized in like forearm muscles and stuff like that, and that's common when like nervous patients are like squeezing the chairs because they're afraid, and then they go in the scanner and their forearms are really tight, or if they're chewing gum like a maniac, or if they're like a runner or something and they went for a run or whatever, went to the gym prior to the PET scan, then their muscles can be all charged up like this too. This is another classic one. I've seen that 100 times. Just remember brown fat, right? And that's the classic location. So, you've got these brown fat cells that are activated, in thermogenesis. So let's talk about this. So what can you do to reduce brown fat like uptake? So they get hotter the colder the room is. They're trying to warm you up, and that therefore if you keep the room warm, they don't have to be as active. If the patient has a particular problem with it, like you really had a problem with this last time, you can give them benzos, like Valium actually helps shut down that pathway. So a small dose of Valium can help prevent the brown fat activity on a repeat exam. So that might be like a good next step or whatever, but just know you can give benzos to shut down brown fat. All right, next case. So we've got a hypermetabolic thing around the heart, sort of draping over it. So this is thymic uptake, can be normal, can be related to thymic rebound. The trick is, anterior mediastinal masses, lymphoma, right? Lymphoma should be really fucking hot, super duper hot. Thymic rebound should be just like lukewarm. Also the morphology, lymphomas tend to be like ball-like, mass-like. Thymic rebound tends to just drape normally, like hanging like a wet towel hanging over something. Morphology. All right, so uptake in the thyroid, diffuse versus focal. If you see diffuse thyroid uptake, you're supposed to think about Hashimoto's. Most often, that's the buzzword. Versus focal, which could be anything, could be cancer, could be nothing. But you have to if you see focal uptake on a thyroid, next step is ultrasound. Okay. If you see diffuse uptake, you correlate with lab values or whatever. You could still order an ultrasound, but it would be like Hashimoto's. All right. Renal lesion, hot one versus a cold one. This is backwards from what you might think that it would be. So the hot one is actually more likely to be an oncocytoma, which is a benign thing. And the cold one is actually more likely to be an RCC. Now, can RCCs be hot on PET? Yes. Can oncocytomas be cold on PET? Yes. But it's actually more common this way. So that's the trick. All right, we got a ground glass nodule. So what do you know about ground glass nodules and PET? So the way that I deal with these things and remember it, and for the purpose of multiple choice, you should too, If it's ground glass and it's hot, it's actually more likely to be infection or inflammation and less likely to be cancer. And if it's cold, it's more likely to be a BAC or adenocarcinoma in situ. It's backwards from what you'd think. All right, so testicle with a mass. So here's the trick on these things. Seminominous versus non-seminominous. The seminominous ones are hot, so that's the normal kind or more common kind. The non-seminominous ones are cold. So just think, this is, my balls are hot. They're usually hot. So the usual testicle tumor is hot. And it's atypical for them not to be hot. Non-seminominous are not hot. How about that? Okay. Showed this in the reproductive talk. It's just an ovary that's hot. So what does that mean? Well, it depends. Remember, premenopausal ovaries can be warm, so like follicular phase, and then postmenopausal ones should not be hot. So a postmenopausal ovary that's hot is that's a cancer. All right, so last one here, we talk about chemo versus radiation imaging windows. When do you do the PET relative to therapy? So you don't want to do it right away for either one of them because you'll get false positives and negatives and that kind of stuff. So you want to avoid stunning, that is a false negative, stunning immediately afterwards, and then massive inflammatory reaction too can give you false positive. So chemo 2 to 3 weeks, and then radiation you have to wait longer because of the inflammation. So I think 8 to 12 weeks. All right, just a quick rehash, and this is super duper testable. Tumors that are PET cold, BAC, carcinoid, islet cell tumors sort of in that ballpark, RCCs, anything that's mucinous, prostate. Some people will include HCC can be in this also. Depends on how aggressive it is. It actually has an enzyme that takes the phosphate back off, and you'll have that way your FDG will just diffuse right out of the cell. That's I talk about that I think in one of the liver talks or in my book. And then things that aren't cancer but are hot: infection, inflammation, ovaries in the follicular phase, muscles, nervous people or people who've had insulin, brown fat, cold room, remember to give them the benzos, and the thymus, especially thymic rebound. All right, that's it.